topical anesthesia? What are the hurdles that are faced, and how do we manage them? Learning to cope up with the anxiety of the patient. Dr. Mohit sir has very well demonstrated this in his talk, that how to cope up with the anxiety of the patient. And finally, we want a happy patient and a happy doctor. That is our ultimate goal. So what are the advantages of topical anesthesia? The disadvantages of local anesthesia, they become the advantages for the topical anesthesia. So the risk associated with needle injections are positive pressure, posterior pressure, iris prolapse, choroidal hemorrhage, retinal detachment, postoperative diplopia, optic nerve injury, misdirection of anesthesia into the subarachnoid space or even to an artery. These are the potential complications that can occur with a retrobulbar block, which most of us we don't have that. But just to mention, these are the injection, risk associated with needle injections. So, and on the other hand, now the expectation of patients has increased, because with time the patient wants you to improve. The expectations increase. Now, how to cope up with them? You need something new, and this new thing comes without any expenditure. So the patient wants immediate results without pain, without downtime, and often without sutures. The advantages of keeping the cornea wet and lubricated is there from the moment the surgery is complete. From a patient's perspective, visual recovery is rapid, eliminating the need for a patch after surgery. An early application of eye drops postoperatively that help prevent complications and improve surgical outcomes. These are the advantages of topical anesthesia over the retrobulbar anesthesia. Now, what is the feel for need? Is it peer pressure? Definitely, because most of the surgeons in town now are doing phaco and topical anesthesia. So you have this peer pressure and you feel the need for this shifting. Patient's demand, yes, of course. My first case, I will tell you all, my first case was because of patient's demand. I'll come to that later on. And the need to upgrade. As I told you, this is the upgradation with minimal or no expenditure at all. So my first patient was a very close friend's mother who was operated under topical anesthesia at Lucknow. She is diabetic. She was not able to travel now because of some problems in her leg. So she wanted to get the cataract surgery done locally, and I was her preferred surgeon. But the only thing was she didn't want the cataract surgery to be done under local anesthesia, because she had already experienced what are the benefits of topical anesthesia. So that was the pressure and the patient's demand that made a need to get myself upgraded. There was a mental block, as I had, everybody has that mental block. So how can we switch over from this mental block? That is by discussing with colleagues doing topical phaco. Sanjeev sir was the first person and the one who I have been troubling again and again to clear my doubts how to switch from local to topical. Mohit boss is second one. So I always used to discuss with them what are the steps in which you get these problems and how to overcome them. Then I started watching videos of all the prominent surgeons who do phaco and topical anesthesia. I have also attended Sanjeev sir's OT, attending OTs of surgeons proficient in topical phaco that I have done. I have been to OTs of Dr. Sanjeev Gupta whenever I had a chance to visit Lucknow. So this is how I overcome my mental block. Then the first case, as Mohit boss has already told us about this, the patient should be very cooperative. He should be willing to go on the topical anesthesia. The other eye has not operated on the block. Because the other eye has been operated under block, he will be comparing the pain sensitivity with the eye operated in block, and definitely initially you will have problems with that. The patient who is not an office squeezer, Dr. Mohit has already told us. The nuclear grade, not too soft, not too hard. Otilis should not be long. The surgeon should be at ease. If the otilis is very long, the surgeon is already under pressure. So you should be at ease. Dim the illumination while you are draping. Supplement with the local anesthesia whenever it is required. And initially, when you are starting the surgery, treat both the eyes with topical proparacaine. So what is the learning curve associated with this? Initially, you select cooperative patients, then when your experience increases, you become more proficient in doing topical phaco, you become fearless, and you start doing topical phaco in all the patients. Now you get one presumed cooperative patient and a complication occurs that shatters your confidence and you are back to blocks. But once you are back to blocks, now you are a experienced surgeon, so you don't have to start from scratch. You're experienced surgeon, now you can slowly and steadily start the cases again and slowly build up your practice on the topical anesthesia. What are the hurdles faced? What should be my method of topical anesthesia? Will it be a jelly or an intracameral lignocaine? Believe me, both of them work. Now I'm doing initially I used to do under jelly, and now I'm doing under intracameral lignocaine, and I feel that intracameral lignocaine is better. The most important step is doing CCC, because after that both your instruments are inside and the patient cannot move. So during CCC you have to be very cautious, and you should tell the patient that now the step I'm going to do requires some cooperation. And a cooperative patient suddenly sometimes becomes uncooperative, so you need to talk to them timely. Patch or no patch is your own choice. There are some surgeons who want to patch, I don't patch. And when to start inserting eye drops postoperatively, because I'm not patching, I'm starting it instantaneously. The first drop is put on the table itself. The steps in phaco requiring special attention are disinfection initially, insertion of eyelid speculum, microscope light, corneal incision, starting phaco emulsification, and IOL insertion. These are the steps which we need to be very cautious, and we should be talking to the patient at that time, because we know that if the patient is not looking towards the light, or he's moving his side here and there, then these are the steps in which we can have problem. I will be showing you one video. This is my first case. You can see that the patient is not very cooperative. This was my first case, and you can see that even the draping has not been done properly, because this was my first case. So, and I'll just show you initially during the CCC itself, because the patient was not very cooperative and I had chosen a wrong case. So what happens? The rhexis extends. So now I am going to do the part of the rhexis will be done as can opener one. What after that, after completing it with a can opener style, I will be collapsing the nucleus in the anterior chamber. You can see this, the nucleus has been collapsed in the anterior chamber, and then the phaco was done in the anterior chamber, putting visco again and again. A corrosive viscoplastic was put initially itself, and finally the case looks like this. So we are finished with the case. So this was my first case, and believe me, first case will be a problem with you, but you start doing it. So surgical outcome depends on the patient cooperation. The most uncooperative amma becomes cooperative just by talking to her. Keep talking to the patient about topics not related to surgery, as Mohit sir already told us. Whom not to take under topical anesthesia: the young anxious patients, patients not cooperative during indirect ophthalmoscopy or a scan, patient who has other eye surgery under block, cases in which you anticipate complications like PPC, PEX, pseudoexposition syndrome, very small pupil, etc. Ultimate goal is a successful surgeon and a happy patient. Thank you.
Dr. Navindu, that was a very, very honest presentation, in the sense that you not only guided all the audience, but also shared your first experience. In fact, you said that video, which was your first surgery. Now,
sir, I would like to add one thing.
Yes.
Why should we switch over from local to topical? Initially, I was doing SICS and phaco almost in similar numbers. So almost was 50-50. But once I started doing phaco under topical, I did not switch over in SICS. So I was doing SICS under block. So what happened? Most of the Ammajis, they started switching from SICS to the lowest, the package that I had, and the topical phaco. So that was the switch. And obviously, because financially, there is not much difference in the expenditure of SICS and phaco, we all know. But the switch, it becomes, better for us. if you're in a private practice.
That
And now I
also
do almost 99.9% topical phaco.
that also emphasizes that how much important it is for that patient to have that experience which is painless as far as anesthesia delivery is concerned, and equally painless as compared to local anesthesia when doing under topical. So it is a patient experience which it will definitely give you numbers.
Yes, sir.
Now,
Yes, sir.
now we will switch to Dr. Rajat Mohan Srivastava, and he will further our journey of this topical anesthesia by extending
Sir, I
this.
had a comment to make about Dr. Navendu's presentation.
Yes, yes, boss.
Yes, please.
Yeah. So specifically, the video that you showed was like it was not an ideal case to be performing phacoemulsification. It was a mature cataract. Then secondly, when you encounter an extended rhexis, again, that would be criteria for conversion to probably SICS for a beginner. And then you are doing it under topical anesthesia. You also say that it is your first case. So by and large, that was a mistake, and you are very lucky to be through with it without complications.
So actually, as I told you in the beginning itself, that my first case was a forced one. That was my very close friend's mother. She was a diabetic.
See, all the more reason. See, all the more reason you have added another comorbid condition. Being a VIP is a special condition. It puts additional pressure on the surgeon. So that was something which should be avoided.
We need to join hands in front of him and go ahead. That was that case for me.
If for me, if it was a VIP with this kind of a cataract, I would have probably done an SICS and got away with it. Probably the repeatability of the procedure and need for God to intervene to save me would be slightly lesser.
Thank you so much, doctor. Dr. Gupta,
All
can
in
you
all,
proceed, please?
it was a good presentation.
Thank you, sir. Thank you very much, sir.
So I will now invite Dr. Rajat Mohan Srivastava, and he will further this journey of topical anesthesia by extending its application to trabeculectomy. Over to Dr. Rajat.
Thank you, sir. Thank you, Sanjeev, sir, for giving me this opportunity. And also, my thanks to the AIOS for giving me this opportunity to present this presentation on trabeculectomy under topical anesthesia. So one thing we need to understand is that topical anesthesia has become a need for cataract surgeon primarily because the incision size has been going on smaller and smaller. So the safety of the surgery has increased because even if there are movements which happen in cataract surgery, they really don't make much of a difference because the entry size of the wound is too small. We have moved to almost 1.8 now. So topical anesthesia for cataract surgery is almost like a norm today. But when it comes to trabeculectomy under topical anesthesia, yes, there are limitations. We do understand that for any anesthesia, there are certain objectives which we want to fulfill. We want to have that patient should have a painless experience. At the same time, we should not face problem because of ocular movement. So akinesia is always useful, and it is always better that the patient forgets all surgical experience, so he is always happy after the surgery. But what we need to emphasize upon that whenever we are choosing for anesthesia for any procedure, we need to weigh between the safety of the procedure, surgeon experience of the surgery, and the eventual outcome. So we need to strike a balance between the safety profile and a comfortable surgeon with the outcome. And if we are able to do that, most of the time we'll be achieving good results with the right anesthesia for that particular surgery. In trabeculectomy, yes, optic nerve is already damaged, and we know there are complications which can happen to optic nerve with retrobulbar and peribulbar injections. So sometimes to have an alternative is a need for trabeculectomy. In the past, we have been often using general anesthesia for people who really cannot afford to have a retrobulbar or a peribulbar block because of extensive damage to the optic nerve and the chances of having a wipeout phenomenon. So we often resorted to general anesthesia, but general anesthesia in all the settings are not possible. So then in those settings, again, where you have got advanced disease and you really cannot afford retrobulbar, peribulbar anesthesia, those are the cases where you need to have an alternative, and a topical anesthesia is often a choice in those cases, which as a surgeon, as a glaucoma specialist, one should have an experience with topical anesthesia. So whenever a need arises, it can be done. But trabeculectomy itself is a procedure which is loaded with complication, not only post-operative, but also intraoperative. And if we have another step which can enhance the rate of complication in form of retrobulbar, peribulbar injection, it is best avoided. But then we really didn't know if this thing is going to work. But in early 21st century, there have been studies where after the phacoemulsification was becoming a common practice under topical anesthesia, phacotrabeculectomy had also been tried under topical anesthesia, and slowly and gradually it was seen with various studies that topical anesthesia trabeculectomy was a new reality. I mean, now with time, I'm sure it is going to become a very commonplace, just like cataract surgery. But yes, it is on the horizon. It is becoming new reality for all the glaucoma surgeons that they can go ahead with topical anesthesia without compromising on patient experience, surgeon comfort, and the outcome. In fact, a lot of studies have even shown that if we compare topical anesthesia with peribulbar, retrobulbar anesthesia, and trabeculectomy, they more or less have the same outcomes, and patient experience has also been good. And at the same time, the chances of complication associated with injections are reduced. But when it comes to a surgeon, when you have to move as a glaucoma surgeon, if somebody has to move to topical, obviously there are so many doubts which we have. How are we going to manage the ocular movement? How are we going to see that we have adequate exposure? Patient is anxious because he's already aware that, okay, now I have to undergo surgery, the disease is advanced, it is not getting controlled with medication. And what about pain? Because he has experienced pain in past, he's having some allergies, some form of complication which is preventing him from continuing medical medication. So topical anesthesia, it becomes a challenge even for a patient to decide for whether he'll be able to undergo the surgery, and also for the surgeon as well, because of so many complications which are usually associated with trabeculectomy. But as has been pointed out previously, the biggest thing is the mental block. Now, if you are a surgeon who is competent to perform trabeculectomy under peribulbar anesthesia or retrobulbar anesthesia with good confidence, I think you can. I mean, I would say a surgical load case of say, at least 100 surgeries in the past you have done, and you are good at making flaps and performing your trabeculectomy routinely, then I think one can think of shifting to topical anesthesia as well. That can be augmented with intracameral anesthesia or sometimes even with conjunctival anesthesia if required. Now, to achieve the desired success, it has been very well emphasized in previous talk that you need to have the right patient selection. There is no point having someone who is not cooperative. If a person cannot hear you, doesn't understand you, person cannot fixate anywhere, often happens in trabeculectomy, or a person with head nodding movements, or because most of these patients are old, sometimes neurological illnesses are there, and even hearing loss. All these things make patient very uncomfortable when they are undergoing for surgery. They are not able to cooperate with you. At the same time, obesity, diabetes status, or some COPD, which can affect the draping of the patient for the surgery, can again be a problem. And then if you want to have a good cooperative patient, you cannot afford sedation. So that again becomes a problem. So when it comes to selecting a patient, you need to have a patient who is, say, moderate to severe glaucoma with good fixation and is able to understand you. And you know that eyes, it is a possibility to have good exposure without compromising any other tissues. So when it comes to surgeon, there has to be adequate proficiency for performing for surgery. You need to have confidence. You need to overcome you need to have belief that it can be done, first of all. And when you're doing surgery, because the eye has to be in downward gait for most of the time of the surgery, it is often good to give breaks to the patient where the patient can look down in between so that he gets a break and you can perform the surgery. And with the anesthesia, with the bulbar block, with the retrobulbar and peribulbar block gone, you get good conjunctiva without chemosis to work upon, which is very, very necessary when it comes to glaucoma surgery. So with right patient selection and having good understanding of your own abilities, you can go ahead performing a good trabeculectomy and achieve the desired result. I'll just share one of the videos which I have got from my chief instructor. This is Professor Sanjeev Gupta demonstrating one of these trabeculectomy under topical surgery. So it's a limbus-based procedure. And you can see with the cooperative patient, when the patient is looking down, how good is the exposure without the superior rectus traction. And with the superior rectus traction gone, so many other complications which can happen because of it are actually gone. I mean, superior rectus brittle, if one doesn't have to take, it becomes so easy. One of the things which is missing here is that when we do a diathermy, even if we do light diathermy, that doesn't cause much of a pain. And a few drops of topical anesthesia here and there does the purpose. You have to be very gentle and careful while holding this flap. And this is the time where I'm telling you that you need to give those wriggle breaks to the patient, where you can just leave the flap and ask the patient to look down. At this point of time, intracameral injection of lignocaine helps. Not only does it reduce the pain associated with performing iridectomy, it makes the overall experience good for the patient. You can at the same time, you can make a side port entry, which will help us in titrating the bleb when it comes to. You can see the amount of bleed is less just because of one inadvertent injury to the blood vessel. There is slight chemosis. Otherwise, it is very good. Look at the conjunctiva. I mean, absolutely no chemosis anywhere. This kind of conjunctiva is going to give very good end results when we follow up these patients later. And in fact, in one of the studies where we have compared the long-term outcomes with topical anesthesia have been equally good compared to peribular anesthesia. So we see that the patient is happy with all ocular movement, no pain, and a relatively safe surgery performed in these cases. So trabeculectomy under topical anesthesia is definitely a reality, which should be encouraged in patient because it is not about your own choice. There are times when it is a need for patient, especially in those advanced cases. Thank you very much for your patient hearing, and thank you, sir, again for giving me this opportunity and the video. Thank you, sir.
Dr. Raja, that was very convincing, and I hope few of our audiences may go ahead and try this, which will be increasing the safety of the procedure and the safety of the glaucoma progression as far as the IOP rise associated with the local anesthesia is concerned. Now I'll be talking about the Trojan horse anesthesia. This is a modified or augmented topical anesthesia which can be used for pars plana vitrectomy. And I've been using this technique for quite some time now. Rather, I have one publication also credited to this technique. So the context is that, as we all have discussed and we are very well aware, that topical anesthesia is a choice for phacoemulsification in routine, and here we are sitting here and trying to extend the horizon by incorporating other surgeries as well. So we'll see how can we do this vitrectomy and the topical anesthesia. Now there's a sort of small background story here that I was operated a patient for cysticercosis, and then there was some leak from one of the sclerostomies because it was a sutureless surgery. And then next day I had to augment some IOP plus I have to put a suture. So I thought that putting in some amount of lignocaine would help in anesthetizing the patient. I didn't do it under local anesthesia because it was just a scleral suture. So then the patient claimed that when he was going into the OT, he could see something, and when he came out, he couldn't see anything. And I was puzzled because I didn't do anything to the retina. But then I realized later on that probably in a vitrectomized eye, when I put in intracameral anesthesia, this solution must have percolated into the posterior cavity where the vitreous was missing, and the anesthesia went ahead and anesthetized the retina. So then I realized that this solution can actually anesthetize the retina as well as other tissue of the eye. And because there was a complete recovery the next day, as you can expect out of any local anesthesia, so I was convinced that this is a temporary anesthesia which gives very good anesthetic effect, which lasts only for few hours. So I'm sharing these images of this patient who underwent vitrectomy and followed by intravitreal lignocaine injection. So after having that experience, I thought of using intracameral lignocaine as a tool to anesthetize to the ciliary body, the pars plana, because these structures are lying very close to the zonules. So I expect if I put in some amount of lignocaine as we use intracameral anesthesia and wait for time to percolate it down and anesthetize the pars plana also. So we devised this study where we had selected patients undergoing vitrectomy for various reasons, but excluding retinal detachment because there we would like to see indent and see peripheral retina for possibility of any break. So we excluded those patients and we graded the pain sensation as per the visual analog scale. And these are the results. So there are 114 eyes and majority of them were males. The surgical time was about a half an hour and the pain perceived was on a range of 0 to 9. It was 3. And the range of the pain perceived by all the patients was 0 to 8. And median was 3. And 100, that is 87.7% patients who opted for the same technique, same anesthesia, again, if they are supposed to be operated again. And the pain scores were not affected by the age or gender or educational status of the subject or indications of surgery and the use of silicone oil in case we had to put in silicone oil for any indication. So I had this experience, and till then I have been using this technique in majority of my patients. Yes, I do have few selection criteria that I don't usually use this technique in patients in whom I have to do some kind of scleral indentation or in whom I plan to do endo laser or laser using LIO, because I believe that intracameral anesthesia will not percolate into the vitreous cavity till it has had a vitrectomized eye. So I don't expect retina to get anesthetized till we have an empty vitreous cavity. And very important thing here is that one should wait for at least 2 to 3 minutes once you have injected intracameral lignocaine in the anterior chamber. And make sure that when you are injected, just let some aqueous seep out so that the intracameral anesthesia agent, which is used in a concentration of 1%, doesn't get further diluted by the aqueous. So you let the aqueous drain out, inject intracameral anesthesia, and then look at your clock. Give it some time to percolate and anesthetize the ciliary body and pars plana. And then when you start with your sclerostomies, which is supposedly the most painful procedure, use a trocar cannula set so that repeated entry and exit doesn't disturb the pars plana. And in cases, you can start with a situation where you have a media clearing surgery to be done without much manipulation needed. And this will build up your confidence. And about the utility for the patient, I feel that not only this experience would be less painful, but patients have also reported, especially in cases with media opacity where I'm doing it for vitreous hemorrhage, patients have reported gain in vision immediately after surgery. Although the gain further continues and you have better vision next day, but even after the surgery, they can perceive this change. And you can let the patient off without any patch because the muscles, the ocular movements, the lid, they all are working fine. So the conclusion of my talk is that this is possible that we can use Now I have used the word Trojan horse here because this is something like a legend, which is supposedly in a battle. It was found that because the attacking army could not breach the walls of the fort, so they left behind a horse filled with some soldiers inside. So it was an artifact left behind, and the people inside the fortress, they thought that this is just a souvenir left to them. They pulled it inside, and during the night time, the soldiers, they came out and they opened the door. So I have named it accordingly, that you let lignocaine go inside from one door, and it will disarm the anesthesia, the sensation and the pain sensation of the ciliary body pars plana. And then you can go ahead and create sclerostomies to reach into the vitreous cavity. So as per my experience and this study, I have concluded that this anesthesia provides adequate analgesia, and it is safe for 23 gauge, which we have used in this particular study, with high patient acceptability. So I hope that this will spark some idea in your mind, and maybe that you will also try this in selected patients of yours. Thank you. So now we have another speaker. We will talk about squint surgery under topical anesthesia. Now this appears a little far-fetched because traditionally we all have been convinced that intraocular structures are well anesthetized by topical anesthesia. But here we will have Dr. Siddharth Agarwal from our university. He is a strabismus and a pediatric ophthalmologist who will explain to us how and why to do strabismus surgery under topical anesthesia, which is so limited to the child pediatric population. But let's hear him out. Dr. Siddharth, over to you.
Please unmute yourself.
Yeah, I've done that. So thank you, Dr. Sanjeev, for having me here. And the session is quite special to me as it has probably the most talented senior that I have come across and equally talented juniors. So I would be speaking on strabismus surgery under topical anesthesia, and seeing all the surgeries earlier, this should probably be the most painful considering the manipulation of the extraocular muscles that is involved in strabismus surgery. So about 3 to 4 years back, I was quite apprehensive about topical anesthesia, but gradually I've been doing strabismus surgery under topical anesthesia in a selected number of patients. So what is the situation in relation to strabismus surgery elsewhere? In United States, most of the strabismus surgery is performed under general anesthesia for medical legal concerns related to analgesia and amnesia. In Singapore, it has been on for quite some time. There are plenty of reports, and gradually the acceptability is increasing elsewhere because there are some clear advantages which I discuss here. When we are doing adjustable surgeries, it allows adjustment on the table. You are able to ensure a diplopia-free primary gaze. And if the patient is under a block, this adjustment has to be done on the third thing. So a good number of patients of concomitant deviation or small angle deviations, we are able to perform the adjustment on the table with patients being under topical anesthesia. Similarly, when adjustable sutures are used, sometimes you have to titrate the correction, and this is also possible with greater ease under topical anesthesia. In bilateral surgeries, you don't want to patch both the eyes. So again, it has an advantage. And all the disadvantages of block go, such as chemosis and rise in the intraorbital pressure. It is obviously indicated in patients who are sensitive to xylocaine. Now, Surgeons who have performed about 100 strabismus surgeries should be able to try this. And another criteria that I've added is that you need to be a reasonably experienced surgeon when you are upgrading to topical. For strabismus, it is about half an hour of surgical time for 2 muscle surgery. If you take longer, then probably you need to first polish your skills more before you upgrade. Regarding the patient, it should be a cooperative patient, preferably over 18 years of age, and should be willing to bear some pain. You can't promise a painless surgery, painless strabismus surgery when you are performing surgery under topical anesthesia. It should be limited to horizontal muscle surgeries and initially only recessions, because greater amount of manipulation is involved in resection surgery, which can be uncomfortable. And whenever you are performing adjustable or bilateral surgery, it has a clear advantage. With regards to modification in steps, preoperative use of xylocaine jelly and phenylephrine drops to reduce the vascularity. Intraoperatively, don't try the fornix incision. The paralimbal incision provides a wider exposure with minimal manipulation. Use xylocaine prior to hooking the muscle. There should be minimal manipulation. Pull on the muscle should be minimum. This you have to tell your assistant. Very often the muscles get pulled. So analgesia is ensured by xylocaine, but not the discomfort related to the pull on the muscle. Minimal cautery and preferably heat cautery, because heat cautery is less uncomfortable compared to the electrocautery. And using tissue glue for conjunctival closure not only minimizes your surgical time, but also reduces the discomfort associated with manipulation of conjunctiva. Do not pull. Minimize the electrocautery. You should be confident about identification of the muscle. You can't be fishing for the muscle in a patient who's under topical anesthesia. And an important point is that you have to connect the monitor, because oculocardiac reflex is often exaggerated in the absence of block. So specifically when you are dealing with the medial vectors. So although the patient is under topical anesthesia, the monitor should be connected in all patients who are being operated for strabismus. Now this is a patient who underwent resection surgery for exotropia in the left eye, and I would be showing his video. Now these are the initial traction sutures, which we proceed as usual. We would be giving the modified von Nuden incision to ensure a wide exposure. This is the recession of the lateral rectus muscle, which is being shown initially. The muscle is hooked with minimal manipulation. Heat cautery has been used, and then the muscle is anchored onto the 6O vicral sutures. The muscle would now be disinserted and reattached at the recessed site. The conjunctiva is closed with fibrin glue. Now on to the resection. This is the medial rectus. One has to be extra careful while handling the medial rectus, because firstly, the space is slightly lesser. It is more painful and there are greater chances of oculocardiac reflex. The muscle has been identified. Heat cautery would be done and the muscle anchored. The stump is now removed and the resected muscle sutured back onto the original insertion site. Middle suture is being given, and finally we reattach. The adhesions are severed and we reattach the muscle, reattach the conjunctiva with fibrin glue. Now this is a small video to show the immediate post-operative mobility, and this is finally the response of the patient. So the pain is tolerable. You can't promise a pain-free surgery. Now, another patient of traumatic cataract with sensory esotropia, he underwent a topical phacoemulsification followed by, the recession surgery is done first. So he underwent a medial rectus recession followed by topical phacoemulsification in the same sitting. So thank you for a patient hearing, and I'm open to questions should there be any.
Very nice, Dr. Siddharth, and you have not only explained how to do it, but also convinced me as well as the audience that this is possible. Although you have been also very practical in cautioning the issues related to pain and selection of patient. And I think it will help few of us to switch to topical anesthesia, looking at the advantages as per the given conditions. Now I'll proceed to my talk on manual small incision cataract surgery, why and how. So I'll be very quick in my slides because I want to emphasize more towards the surgical video which I'll be sharing. So rest of the things are merely same repetition of the same issues which my previous speakers have already emphasized on, that a manual is small incision cataract surgery, which is a very popular technique among all of our cataract surgeons, is there for us to those patients in whom we cannot do phacoemulsification for various reasons. And it has been proven in literature as per few of publications, few of which are mine, that it is as painless as a topical phaco. And there are issues which should be taken care of, and the patient's experience is going to be wonderful. So the safety issue is all well known to all of us, that putting a needle in the orbit will have issues which Dr. Mohit and Dr. Navindu has handled well. And there's a glamour associated with this patch, but it looks only good on few of the individuals, rather not all of us. So the patient would be liking to avoid it, and this is possible only if the ocular movements and lid movements are well preserved. And it has been very well advertised that no injection surgery has an impact, as Dr. Navindu was telling. The patient's experience is a different one if he is not given local anesthesia. And how can we do this? So as with rest of the surgeries, you have to be good at it, because you cannot take chances in making a mistake. Communicate with the patient and remove that mind block that it is not possible. So I'm just repeating the statement that manual small incision surgery is possible under topical anesthesia. Now proceeding to how do we do that? So I have few tips of my own, although these are all individual variations and people can experiment upon. I use specifically lignocaine 2% jelly in place of drops, and I believe that it has a longer contact time and a deeper anesthesia plus prolonged anesthesia as per the formulation allows the contact time to be longer than drops only. And I will advise minimal surface handling, because as Dr. Mohit said, the touch and pain may not be differentiated by few of our patients. And do use intracameral lignocaine in starting. If you have very averse to lignocaine putting any molecule in the anterior chamber, you may not use it later on, but starting use it. Rather, there's a comparative study in phacoemulsification on use of no intracameral anesthesia versus intracameral anesthesia for phacoemulsification patients. And it was very conclusive that patients with intracameral anesthesia do have comfortable experience, because the possibility of stretching the globe and handling the iris is always there during phacoemulsification. I will advise against using bipolar cautery, because the current which causes a sensation which cannot be overcome by topical anesthesia. IOP rise and stretching of the globe should be avoided, and subconjunctival injections again cause some pain, so I usually avoid them. Now here we have a nice video where I'll show you. This is a recent video where you can see the surgeon has been planning a phacoemulsification in a very, very brown and hard cataract. And this is an initial shying away of the eye when intracameral anesthesia is injected, because the pH of the intracameral solution is little acidic. This is the formulation limitation, and it causes irritation of the iris. So patients will usually try to blink and have a protective reflex when you inject it. But over a period of time, the stinginess goes away, and now rhexis has been completed. And you will be surprised that I am showing you a video of phacoemulsification, but just be patient and see. Now, during this phase, I realized that the bag is not very stable. So I decided to switch to manual small incision cataract surgery. And you, as you could guess, this patient was under topical anesthesia. A very, very light electrocorticoid is being used just to have control of the bleed. And the same incision of the phacoemulsification has been extended further to incorporate a small incision cataract surgery tunnel, and then enlarging the tunnel. So here I am able to also demonstrate that this is a useful technique. If you can actually have a situation where at some point of time you decide to switch to small incision cataract surgery, and if you are well versed with SICS and the topical anesthesia, you can do that. Now the rhexis being extended because we need to deliver the nucleus, and you can see the nucleus is not very stable at the point. Now it's a large nucleus, it's a hard nucleus, and having unstable zone use adds to the trouble. Now this is a situation where you will not like to experiment with phaco, so it was a good choice on my behalf that I switched to SICS. It's a large nucleus. Nucleus has been delivered by a fish-hook technique. The IOL has been implanted, and you will see a twist here. Now there's some cortex left behind because I decided to implant the IOL and then go ahead with the irrigation aspiration. This burst of bubbles, which you will see now in slow motion, suddenly cause some fluctuation in the chamber, and we have a PC rent right here in this area, and the vitreous starts prolapsing. So it becomes a special case where the surgeon, in spite of taking extra caution, was unable to avoid a posterior capsular tear. And because the IOL is in the place, I don't want to disturb that. So I am conservatively managing the vitreous strands and putting the air bubble in the chamber to stabilize and keep the vitreous away. So that was one surgery where I could demonstrate that you can have your desire of switching to small incision cataract surgery from phacoemulsification, given a situation where you decide to do so for safety reasons or any other reason. And even in spite of having a complication, I could finish the surgery. So I'll just add one more thing about intracameral anesthesia, which I routinely use. It has been very well demonstrated in studies that intracameral anesthesia not only helps in anesthetizing the iris and ciliary body, it also helps in sustaining the mydriasis. And it has been also known to help in floppy iris syndromes. So this is a great utility of topical anesthesia augmented with intracameral anesthesia. And as per various studies, putting 1% or 0.5% lignocaine in the anterior chamber doesn't cause any additional harm to the endothelium, which is supposedly one of the most fragile tissue in the eye. So this finishes my talk, and I am willing to take any question for whole of my team if there are any.
So in the surgery you showed us, in the SICS one which was converted.
Yes, Mo.
Just wanted to know, in the surgery that you showed us about the topical SICS which was converted into, phaco was converted into SICS, and then there was rent. So in this case, if we don't manage the vitreous prolapse properly in the anterior chamber, is it going to be a problem in the early or late postoperative phase?
See, my philosophy for this situation is that you should manage that vitreous should not prolapse into the wound. Now, I couldn't show you the whole of the procedure but I did manage to constrict the pupil down to a size which was fairly less than 6 millimeters. And then if there's any prolapsing vitreous which would be traveling through the pupil into the wound, it would definitely distort your pupil. So once you are sure that you don't have any vitreous peeking into the wound, there isn't going to be any issue. There will be no traction, there will be no irritation of the iris. And at the end, when I pushed in air, see, the issue was that one way to go was that I would have done a vitrectomy using a vitrectomy cutter and cleared the chamber, putting in triamcinolone, identifying vitreous. But then my concern was also that usually in a situation like that, if you go inside with a vitrectomy cutter, you may likely to actually damage the capsule, the remaining capsule. And which what I could see was that the IOL was perfectly sitting in the back, and there's not much of the vitreous which was displacing. See, vitreous, if it would be there in great amount, it is going to displace your IOL inferiorly, away from the site of PC rent. So I could judge that the vitreous is not disturbed to that extent that I had to go ahead and stain the vitreous and remove it. And the pupil was round after putting intracameral pilocarpine, and I could form the chamber nicely with air bubble, which kept the pupil round and kept the vitreous, any potential vitreous away. So I think it worked well for the patient also in post-operative phase. I was trying to find out a post-operative picture, but I couldn't. So I couldn't place it here, but he did fine. Rather, I would say that if I would have attempted a phacoemulsification, and if he was destined to have a PC rent, then I would have been in a bigger mess with a hard nucleus and a large nucleus with a PC rent in the situation.
Thank you, sir. Thank you very much, sir. That solves my query.